My name's Johnnie Kleinschmidt. I'm a physical therapist, and I've been out here at Memorial since 2005, I think, maybe. Okay. I've been doing women's health pelvic floor therapy for about 12 years. And this is all I do now. I've done all kinds of therapy, sports medicine and outpatient and home health and neuro and all that stuff. And it's great, fun, but this is my niche, and I enjoy it very much. And tonight, a lot of my slides will be pointed toward pain, but we're going to include menopausal issues, because unfortunately, as we do go into that fun stage of life, pain sometimes is associated with it, or things can lead to pain. So I hope you guys enjoy, and we will have questions at the end. So if you don't mind, save your questions or make little notes. If something pops in your mind, just save them for the end, and I'll do my best to answer them. And I do want to ask one question before we get started. Does that look like you? Do you ever recognize that look or that position? Y'all, I enjoyed myself when I found that slide. Oh, I laughed and laughed and laughed. But anyway, this is actually a Fresh Step Cat commercial, and I did find it, and Lauren helped me get it in my talk, so I have enjoyed that. First and foremost, before we get into anything, and I do this with my patients when they come into the room and we're sitting face to face for the first time, the first thing I get into is anatomy, the way the pelvis is made. It is extremely important in your rehab, and if you understand what you're working with, it's a little bit easier to fix it, so to speak. This is an overview, very, very simple. I'm not going to get into extreme detail, but when I was in PT school, just put it this way, when I was in PT school, we learned on day one, I guess, in actually pediatric therapy, that when you want to help control a kid and their motions, you hold them by the pelvis. The pelvis is the center of control of the body and of motions. And if you think about it, it's the thing that everything's connected to, up above and down below. And that pelvis and its alignment and how it's functioning has a lot of control over the rest of your body. So, I just said that. These are just some points. It's the architectural center of the body. It's the supportive structure of the torso, which is the body. It's the temple of the reproductive organs. It holds all those important reproductive organs and protects them, actually. It's the abode where new life grows in us women, not the two guys in the back. It is the site of two principal departments of elimination. And if those things aren't working well, we all understand how frustrated we can be. And of course, it's where we sit, and we have to sit down sometimes. Some of us don't sit enough. Some of us sit too much, which can be a problem too. Okay, here's that anatomy. What I want you to take from this picture is that bony ring. Those two big flared parts. Oh, I forget I have a pointer on here. These two big flared parts, that's where we put our hands on our hips. It's where we hold babies when we walk around. That's that ring, and what I want you to see is, if you're looking down into it, I'm not real good with pointers, looking down into it, it's a hole. The bottom of that ring, there's nothing bony there. What that is, at the bottom of that ring is a pelvic floor, musculature at the bottom of that. I call it the pelvic hammock, and my patients hear me talk about it like a hammock, and we'll get into that a little bit more. The sacrum, which is right there. I told you I'm horrible with these pointer things. Right there. Okay. That is the back of that pelvic ring that we just looked at. And it's, of course, at the bottom of our spine, which is a very important load-bearing structure in the body. The sacrum, that little cup-looking thing, it can actually, if it's out of place, just any bitty little millimeter out of place, it can affect where our foot and hip and leg and movement, motion. It can have effects on all of that. If it's off center here, it can be off center anywhere down below. So it's really important, more so than a lot of people understand. Lots of ligaments. We're not going to get into the names of those. They're not important. But we have a lot of structural ligaments that hold that sacrum and that bony ring together as a unit, to function as a unit. They not only stop motion and limit the movement, they hold things together, but sometimes they can be too loose. And you'll hear the doctors maybe say SI dysfunction or sacroiliac pain or SI joint pain. That's what they're talking about, is if these ligaments that are around that sacrum are loose or are not doing their job correctly. Tailbone. Oh my goodness, lots of tailbone patients right now. I don't know if there's a virus going around on tailbones. I don't know, but lots of tailbone, coccyx is what it's called. Lots of pain. That also can be triggered by, remember our bowl, our muscular hammock. If that hammock is spasmed or weak or not functioning right, or surgery or childbirth, that tailbone can get kind of caught up in the mix and get angry and swollen and out of place, so to speak, out of sorts. We did kind of already talk about the SI joint. There's that, here's my pointer. I'm going to try it again. Right there and right there is what the SI joint is. We have one on each side, right and left. It's where that sacrum joins that pelvic ring, that bony ring. There's that tailbone down here. So this is the top, this is the bottom. But that is an actual joint right there, like a joint in the finger, a joint, elbow joint. That's a real joint. When I was coming into PT school in the 90s, there was all this discussion about, oh no, it's not a real joint. I don't know if Dion remember if it was an issue when she was in PT school, but there was times when they used to say it was not a joint. It was not a movable joint. Yes, it is. And they finally, I think, agree across the board on that, unless I've missed that discussion. Most of the time, that little area is a problem in women, typically after childbirth or when they're pregnant and their ligaments are lax and things are moving like they won't typically move if you're not pregnant because of that hormone relaxin. But anyway, a lot of women have issues with the sacroiliac joint being unstable, and they think they have sciatica, but they really don't. They have an SI joint problem. So it's easy to pick up if the therapist knows what they're looking for. Fascia. I think you guys have this, don't you? Okay. That's basically, just think of it as a blanket that covers from head to toe. Everything from head to toe. It's connective tissue that just holds everything together. I like to tell my patients, think about when you clean a chicken. You know, that white covering on the meat, not the fat, not the skin, but that white covering that's kind of see-through, that's fascia, okay? But it's not just on the outside, it goes 3D. It's down to cellular level. And if the fascia in the body, if you have a surgery, for instance, like a C-section or a hysterectomy or anything like that, if the fascia is cut, it has to, of course, heal back together. If it's not right and there's a bump in the fascia, heals with this. You know how scars sometimes heal bumpy and not just right like it was once before. It wasn't just perfect as it was before. It can create pain, and you've heard of scar tissue building up. That's usually a fascia issue, and it needs to just be ironed out. I tell my ladies, think about a nice sweater. If you have a little string hanging on it and you pull that string, what happens to the sweater? It kind of distorts. That's the body. If the fascia is disrupted or interrupted, it can do that, and it just needs a little bit of release is what needs to happen. Muscles. Okay, We are so not going to go over all those names, but every one of those muscles can affect your pelvic floor. They are big ones, little ones, small ones, but basically when a patient comes in with pelvic pain, this is kind of sort of the things I have to go through and look at and make sure that this isn't one of the pain generators, okay? Lots and lots of them. But to tie this in with menopause, when women hit that age where the hormones start falling off, our muscles do shrink. They do become, I hate this word, flimsy, okay? Hypotonic is another word that you might hear in the medical field. But when we lose that estrogen, we lose tone. And that's why plastic surgeons are making so much money, because, you know, they pull everything up. And, the same thing can happen to that hammock, that pelvic floor. It can drop, and you've heard of the word prolapse. Okay, well, there's three things in that pelvic bowl that can prolapse. There's the bladder, there's the uterus, and there's the colon. And the way we were architecturally made, all three of those things fit down into that pelvic bowl, and they are ligamented together. So if one is removed surgically, those ligaments are cut. So the doctors, if they remove the uterus, they have to go in and they have to tack up that bladder and tack up that rectal colon back to where it's kind of holding on to something, because that uterus was dead center and it's a load-bearing structure. And when they take that uterus out, it's missing some structure there. So they have to do a lot of tacking, okay? Well, prolapse is when anything, A, B, or C, any of those three want to come down and sink down toward planet Earth, where it should be up here, it wants to go down there. Now, that muscular floor of that pelvic girdle, that pelvic floor, it is responsible for holding those three organs up. And there's three openings. All three openings have to maintain closure. That's that muscle's job. There's no surgery I know of yet that can strengthen a muscle or close an opening that a muscle is responsible for closing. So that's where I come in. And we do things in my office with biofeedback and electrical stimulation and other things. Sometimes I have to fix the orthopedic issues before we can even get to the pelvic floor issues, because they play off of one another so closely. But that pelvic floor, it's, okay, I was in a class. I can't even demonstrate it any better. I wish I had the slides, but I think I'd gross you out, okay? They showed us 3 slides of women at 3 different ages, 18, 45, and 82. Okay, they were cadavers. They were gone to be with Jesus, but they showed us the thickness and the color of the muscles of that pelvic floor. Now, I don't want you to think the pelvic floor looks like this guy, all beefy red, thick, big muscles. No. In an 18-year-old, that pelvic floor is maybe soft pink, not a whole lot of blood flow there, and very, very thin. The instructor said about the thickness of, if you put 12 tissue papers that you put like in gifts, you stack them, and that's about the thickness at 18 years old, with full-blown hormones, prime of your age, and no children yet, okay, no childbearing. So then she showed us the next slide of the 40-something that had, I believe, 3 children and was in full-blown menopause, okay. The pelvic floor thickness had gone from a pink to more of a whitish, with a tinge of pink, but mostly white, but the thickness had gone to about, she said, about 3 tissue levels. Now these are muscles. Then fast forward to the 82-year-old, it was now gray, about the color of that wall. And she said, you take that tissue paper and you poke holes in that 1 page. And that's about the thickness. And these are these muscles that we're dependent on. Okay, it's bleak future, I'm sorry, but there is hope. okay? But the hormones, that's the whole point of that slide series, was what hormones, lack of hormones, does to our floors. So we don't have a whole lot to work with at 18, and it kind of goes down from there. That's why I am a stickler on teaching prevention. Stop the power peeing. I know probably everybody in here power pees, and I got people going, what is that? When you sit down on the toilet and you force the flow, because the phone's ringing, the kids are screaming, or whatever, okay? The power peeing just puts more pressure down, and that's a big no-no. Make sure there's no constipation. Constipation is a huge factor in prolapse of any of those organs in the pelvic floor. So those are some really, really big things you can do to prevent the droppage. Another thing we do in my clinic, in my treatment with my patients, is we do pelvic rotator cuff exercise. There's a rotator cuff here in the shoulder. We also have one in the pelvis. And it is incredibly effective in strengthening and undergirding those pitiful little hammock muscles. They come up underneath the hammock and support the hammock. And it's not part of the pelvic floor. It is actually a hip rotator. But strengthening that hip rotator comes in underneath and does a lot of help for that. Okay, so I'll get off the muscles now. Pain. This was a definition from 2002. I hope it's still the same. An unpleasant sensory experience associated with actual or potential tissue damage. Pain is never normal. Don't ever ignore pain, especially if pain wakes you up in the middle of the night. That is always a sign that it's not okay to look the other way. Now, if you broke your arm and you're in a cast and it wakes you up in the middle of the night, yeah, that's all right. But if it's a normal thing, normal day, and you go to sleep and you're fine, you wake up in the middle of the night and you're hurting, it's not a good thing. These are some causes that pelvic pain, a lot of my patients that have it. Surgery, big cause of pelvic pain. Unfortunately, we need it sometimes. Episiotomies, they're huge generators of pain and weakness. Hemorrhoids, cut denervation, that just basically means a nerve has been cut during the process of surgery. It happens, unfortunately. And scar tissue entrapment. When we've had surgery of any kind, that scar tissue can lay down, and it's very, very strong, and it's very, very bully-like, and it can trap things such as your bowel. It can trap the pudendal nerve, which is important to the whole function of that pelvic girdle and that pelvic floor. My pudendal nerve entrapment patients are very unhappy people, and they're typically hysterectomy, some sort of female surgery has happened, and that's why they've had this surgery. Stretch injury, there's that word constipation again. If you are constantly backed up, which women are notorious for this problem, you can literally have that bowel so heavy it can fall and drop from above and put pressure on the organs in the pelvic girdle and cause long-term problems and prolapse, which we don't like that word. We don't want that to happen. But if you have nothing moving and it's just staying there and getting heavier and heavier, it's going to push pressure and cause long-term problems. So prevention is key on that right there. Stretch injury from prolapse, weightlifting. Believe it or not, a lot of runners are incontinent at an early age because of the pounding, and constant downward pressure on that pelvic floor. Prolonged pushing during labor, but I want to add one more if I could, would be prolonged pushing during BM because of constipation. I'm seeing more and more patients come to me from colorectal surgeons, from women who have had prolonged chronic years of constipation, and now they've had surgery or you have got to get them moving. You've got to, you know, make them stand on their head and do something, but get stuff moving, or they are headed to surgery. And sometimes it is a problem from the pelvic floor. Pelvic floor is weak, or the pelvic floor is spastic or too tight. So I would, if I could add that, I would. And we've kind of talked about entrapment of the nerves. It can be trapped by muscles, ligaments, or bones, or scar tissue. I would add on there. Here's a whole lot of patients that I have that come through. Vulvar pain syndrome. And I wish I could find someone to tell me, and I know all of my poor little patients who have this, they want to know why. Why am I hurting? What caused this? We still don't have an answer. The doctors just say, comes with age. Oop, it could be hormones. I don't know. But here, try this cream and go see Johnny. Sometimes biofeedback helps. Electrical stimulation of the area helps. Different stretches. Just kind of an overall look at the patient is where we have to start and try to figure it out. And we do get better, but it's sometimes very slow. Interstitial cystitis, another biggie. That is actually an autoimmune disease. You've heard of lupus and other autoimmune diseases. IC, which they'll abbreviate it because it's harder to say interstitial cystitis over and over again. But IC, these are usually very frustrated patients. That's just basically constant aggravation of the bladder wall. They usually have ulcers or inflammation of the bladder wall, and that is usually diagnosed with a cystoscope. They go in and they look, or they may take little samples of the wall of the bladder to diagnose that, and it's treatable, but it's a long-term treatment. Major diet changes for these people. There's a lot of things they can't eat, but they also have a lot of problems with the pelvic floor going into spasm, and that's where I come into play a lot of times. Overactive bladder and incontinence, get a lot of those. Overactive bladder, that bladder doesn't know when to be quiet. And it can sometimes be helped by medications, but 99.9% of my patients, they toss the medicines in the trash after about 2 weeks because they can't stand the side effects of the medication. You see the medications on TV all the time. They play those big money, but patients hate them. They absolutely hate them. We can do some things in therapy to help with that, but again, it's a lot of retraining of the floor and a lot of changes in diet that we get into. Sometimes we call it our come to Jesus meeting because not a lot of patients like to hear that information and what their favorite foods get cut. But if you feel better, you don't mind taking them out of your diet if you're feeling better. Incontinence, 2 types of incontinence, stress incontinence and urge incontinence. Then there's the third one, a mixture of the two. And those, unfortunately, sometimes occur together. And stress incontinence is not because you're stressed out. You know, it probably doesn't help if you're stressed out. But basically that means if you are leaking when you cough, sneeze, and laugh, or lift something heavy, or, you know, bend down to pick up your purse and, oh my goodness, I think I need to go to the bathroom. Urge incontinence is usually a trigger brings it on, such as water running, or putting your key in the back door, or turning into your driveway, and I gotta run. Or I had one patient, her trigger was Kroger. She, bless her heart, would walk into Kroger and run straight to the bathroom, even though she had just been 2 minutes before, but it was something to do with Kroger. So I told her, go to Albertsons. Yeah, just try it. Try a new grocery store. Excuse me. Pudendal neuralgia, that's basically pain in the pudendal nerve. The pudendal nerve is that nerve that innervates the whole pelvic girdle. If you're sitting on a saddle, on a horse, everything that's touching the saddle is the pudendal nerve. And if that nerve is trapped due to scar tissue from a surgery or what have you, it's pretty frustrating and aggravating. They have a hard time sitting, hard time going to the bathroom, hard time just dealing with daily things. So, tough one. There's the tailbone. Tailbone. Lots of tailbones right now. I'm going to start putting up billboards. Stop roller skating, stop horseback riding, stay off the tailbone, because I don't think I have any more room for some tailbone patients right now. It's really, and actually I did sign up for a class in October strictly on tailbone patients. It's gotten so popular. I'm not sure. Okay, what I do, my intervention, got to start with an evaluation and sit down and figure out what's happening. Treat restricted joints. All those muscles and joints we were talking about earlier, I have to figure out what's tight so we can loosen them up and strengthen what's weak so we can strengthen it up. If there's this imbalance going on, typically in the pelvic girdle, we got stuff happening, forces transmit in the wrong direction, and got to balance it out a little bit. Posture is huge. Sleeping posture, sitting posture, standing posture, it's a big deal in my pain patients. Strengthening the weak ones. Diaphragmatic breathing, belly breathing. If you've had yoga or Lamaze or Pilates, when they push on that belly breathing, you wouldn't believe the people who can't breathe correctly. Chest breathers. I'm sorry, I keep touching this microphone. Chest breathing is not efficient. People who smoke tend to be chest breathers. People with asthma or respiratory problems tend to be chest breathers. They're not getting the oxygenization that they need. So belly breathing is huge, breathing from the diaphragm, and it also relaxes that pelvic floor. That's why they like it in Lamaze. Teach all that breathing so that baby can come out easier. Improved flexibility of the high tone. Yeah, if we've got that high tone musculature in the pelvic floor, in the pelvic girdle, we gotta bring that down so that things can move. Release that fascia that I talked about earlier, that blanket of tissue. If it's restricted somewhere, and a lot of times with female surgeries, pelvic surgeries, we end up with a lot of fascial restrictions, and it's going to create some problems. Improve the firing of the muscles that all cross over that pelvis. And education. I do a ton of education on our first day. I actually schedule an hour and a half for my new patients because I'm going to be with you and you're going to get tired of hearing me for an hour and a half, and I'm going to give you a bunch of stuff to start doing at home on day one, because what you do at home is way more important than what I do 1 hour a week with you. Okay, questions that I usually get asked. These might be some of your questions. What type of treatment do you do to relieve adhesions? Lots of women have adhesions from old surgeries. That release of that fascia that I talked about, that's one of the things we do. Visceral mobilization, which is actually, I have, it's not voodoo, but it kind of sounds like it, but ways of just moving those organs just to get them mobile again, because if they're stuck down and restricted, things can't move. Our bodies were made to be dynamic. The bladder fills, the bladder empties. If it's stuck down from scar tissue, it can't fill to capacity, so you think you have to pee every 5 minutes if that bladder is not doing this and this. So we have to figure out how to retrain that bladder and get it moving again. That's what I just said. What kind of things do you do to reduce or relieve pain? Modalities, I use machines, a biomodulator, e-stim, ultrasound, heat, all kind of little tricks that help relieve pain and improve blood flow and release spasm. How do you help to strengthen the pelvic muscles? And there's a typo. I know. I just found that. It's Kegels, K-E-G-E-L-S. I didn't know that was up there, and that's my fault. Biofeedback and pelvic rotator cuff we kind of talked about. So those are a few of them. Here's some more. How long does it take? I usually see my patients once a week for about 4 to 6 weeks. If we have to go longer, we go longer. If we don't need the 4 to 6 weeks, we're done in 2, which is fabulous if we can. But is it hard to do the exercises? No harder than you make it. They're pretty simple. I give you lots of things to do at home, lots of tricks. There is an app on phones that have apps now, like your iPhones and your Droids and all that has a Kegel app. And I tell my patients, pull up your phone, put it on, and I want you to use it 3 times a day, because it's a great little tool. Do you help with urine or bowel leakage or incontinence? Yes, it's one of the main things I work on. My goal is that you don't look like this anymore. That's my other cat picture. And I laughed, y'all. That just cracked me up when I was getting my hair done in the salon, and that picture was in the magazine. So that is my patience right there. And he's actually doing a move from the pelvic rotator cuff. Yes, he is. Okay. But anyway, my job is to restore you to a happy, normal, daily life. And with your help, I hope we can get it done.